All right. So welcome everybody to the February 1st, 2023 Trauma Nursing Journal Club. I'm glad you could join us. And for those of you that are not with us live tonight, I'm thrilled that you're picking this up in its enduring matter on YouTube. So thank you for taking the time to at least listen to part of this tonight. Everybody who's on live, certainly feel free to turn your cameras off if you are so inclined. If you don't want to, that's okay. I don't have any problems with that. This is not an overly formalized presentation tonight. So I believe most of you, maybe Allison, you didn't get a copy of the actual journal article since Kathleen just signed up about an hour ago. But I'll send you a copy if you are so inclined. Just in your evaluation, when you give your email, just let me know you need a copy of the article, and I'll send you one if you're interested.
Perfect.
Okay, cool. But other than that, definitely thank you all for being here tonight. I try to do these little journal club tidbits about 4 times a year. This is going to be, I think, actually the 4th one that we've done. So this is going to actually kind of round off the first year of doing the Trauma Nursing Journal Club. So I'm thrilled about that. And like I have said, kind of the disclaimer for all of us that are on tonight is this is being recorded. So certainly you can turn your cameras off if you want. I don't know until I render this whether or not your faces will actually appear on here or not. Sometimes YouTube will catch you in the corner. Sometimes it doesn't. But again, it goes to my channel, and it's not like it's viewed by 9,000 people. I think probably on the average about 30 or 40 people will step up and watch the recorded comments. So what I'll do after tonight is send you a copy of the link to the YouTube channel, and that way anybody who you think might be interested or who couldn't be here tonight can go online and can watch the frivolity that will occur over the next hour. So I think I know everybody on the call tonight, so introductions within this audience are not needed. But for those of you that have tuned into YouTube to watch this, my name is Steve Weinman. I'm with the trauma program at St. Joseph's University Medical Center in Paterson, New Jersey. I run the trauma education program there, amongst other things. And I have nothing to disclose, and the comments tonight are those of mine alone. They are not reflective of any agencies, organizations, or employers who still gainfully employ me after tonight. This is part of what I call the Trauma Nursing Education Series. It's a little kind of a little construct of 2 programs that I have put together and that I provide on a quarterly basis. Tonight, of course, as you all know, you're looking at the Trauma Nursing Journal Club. I had originally scheduled topics in trauma nursing, which is a kind of just a straight talk that either I do or I cajole people into. I see Kathleen's on. Kathleen was kind enough to give a great talk on damage control resuscitation. Jessica Mills did a great talk in December on the fatal triad becoming the fatal diamond in calcium in hemorrhagic shock. I'm putting together my talk. I originally had scheduled it for March 1st or 2nd. I was going to talk about ocular emergencies, but I then realized that the New Jersey Emergency Care Conference is coming up, and I'm putting together lectures for that. And rather than completely put too much on my plate, I'm probably going to wait until after the mid-March conference in Atlantic City, and I'll do one of the lectures that I'm putting together for that as the next topics in trauma nursing. So anyone who's on this call tonight is certainly invited to participate in that. At the end of this program, I will provide a link to you as well as a QR code that you can scan real quick on your phone or click on in the comments box, chat box, and then it'll take you to the evaluation. When you fill out the evaluation, if you want to be included in future installments of the Trauma Nursing Education Series, just give me your email address and I'll add you to my growing mailing list. The rules of Journal Club are pretty straightforward. I usually try to pick out an article of interest to what I say are like-minded trauma and emergency nurses out here, particularly in the northern New Jersey region, but it's not confined only to northern New Jersey. And we look at a little bit, and we look at it from the standpoint of evidence-based practice, possibly ideas for doing research within our own institutions, which would be kind of cool, best practice implementation, and more ardently, and it all is dependent on all of you out there watching live tonight, a little bit of professional banter and socialization, which we try to do at some point throughout the talk tonight. You know, like I said at the beginning, this is not a formal talk. I'm putting together initially kind of my thoughts on the article at hand, but I really do want to hear from those of you that got a copy of the article in advance and got a chance to read it and kind of listen to your experiences with the content we'll be talking about tonight. So let's get into it. The article I chose for tonight was published in, I think it was the November-December issue of the Journal of Trauma Nursing. The title is Pelvic Compression Device, or parentheses, Binder Application Training in Medical Students Using a Mannequin Study. This is a study that actually comes out of Turkey. I chose it for a variety of reasons. First of all, I chose it because the use of pelvic compression devices or pelvic binders is a bit of a hot topic right now in trauma care. And as much as it's a bit of a hot topic, it's a bit of a poorly understood skill for a lot of emergency and trauma nurses. And when it comes to anything that we do from the standpoint of skills or procedures, competence is extremely important. And this article kind of looked to get to the heart of assuring some level of competence in or developing some kind of a threshold for evaluating or assuring competence of this particular skill. So I did pick it. I did read the abstract. I didn't read the article thoroughly before I sent it out and decided to use it. You'll hear tonight, it's probably not the best study in the world, but I think it's got some really good information on it that I'm going to be happy to discuss with you with regards to the use of pelvic binders and some of what the literature review, as the authors in this paper have pointed out, with regards to right now it's not being utilized probably as much as it should, and there's a little bit of controversy, if you will, around its use. So we'll chat about that a little bit tonight. That is the article tonight is out of the Journal of Trauma Nursing, but I absolutely would be remiss if I didn't push our own journal, the Journal of Emergency Nursing, and particularly in the area of trauma. It's not only we want you, it's I want you. I absolutely have the extreme pleasure of being the trauma section editor for the journal, and I am always looking for cool articles for the journal. And these are not research articles. I don't want you to go out and do research. If you want to go out and do research, that's great. But I just want like pearls of wisdom, things that you've seen in your trauma center, maybe a case study that you were involved with that was really an interesting case study. And you're like, boy, we don't see this very often, or had some complexities that are unusual, and you'd like to write it up and get yourself published, which is kind of a cool thing. So if indeed you do want to do something like that, or you have some thoughts on articles that you've been writing, maybe you gave a lecture and you'd like to convert that lecture into an article for publication, reach out to me, both at my St. Joe's email address, which I've got embedded in this particular lecture, or at the address that's listed here, which is rescsteve@gmail.com. The other thing is, if you are interested, go to genonline.org. It's the journals page, and it's got all kinds of author guidelines and things like that that you can peruse if you are so inclined. All right, so let's get into it. Let's talk a little bit about the article and what the article brought to bear tonight. So the article in its introduction really kind of goes over, like a lot of articles do, it talks a little bit about the introduction and lays the groundwork for what the authors put together for their research project. And in their introduction, the authors aptly note and correctly note that trauma deaths are many times trauma deaths are preventable. Particularly hemorrhagic trauma deaths. The literature actually will cite that upwards of about 64% of trauma-related deaths that are hemorrhage-related can be preventable by doing things like controlling catastrophic external bleeding. Kenzie and I were talking about that, obviously Stop the Bleed, before we went online here tonight. And then also recognizing uncontrolled, uncompressible bleeding of the torso, and particularly for pre-hospital providers, facilitating rapid transport to an appropriate trauma center where surgical intervention can hopefully save a life or slow the bleed. But when it comes circling around to pelvic trauma is kind of a big thing. It's believed to contribute up to 10% of the trauma-related mortality that we see in trauma centers on an annual basis. The overall mortality from severe pelvic trauma can be as high as 36%. That's, astronomically high. And we want to try to see what we can do to mitigate that and bring that down. And when we look at pelvic trauma, what makes it so diabolical is the fact the pelvis is an extremely vascular, not organ, but bone. And you can see in the diagram here, just the sheer number of blood vessels and the size of blood vessels, both arteries and veins that enter and circumvent the pelvis underneath the ligaments, are just, there's no wonder why if one of those vessels gets ripped, torn, or severed, that you can have a lot of bleeding. Add that to the fact that if the pelvis is damaged, particularly with an unstable pelvic fracture, where now the pelvis is actually allowed to expand once bleeding occurs within the pelvic girdle, you can exsanguinate into your pelvis. The literature says up to 4 liters of exsanguination. I've unfortunately been involved with a couple of cases where the person completely exsanguinated into their pelvis as a result of an unstable hemorrhagic pelvic injury. So, obviously it's something that we should be thinking about, we should be looking at. And I know within my own shop at St. Joe's, we see a large number of unstable pelvic injuries on an annual basis. Common mechanisms of injury tend to be motor vehicle crashes, particularly motorcyclists, pedestrian struck, bicyclists hit, people who take long falls. So, we think about a lot of the blunt trauma, particularly in the northeastern part of the state with all of the highways and roads and people driving like nuts. It's, no wonder that we could potentially see a lot of these injuries, and probably most of us do. The other thing is understanding what the difference is between a stable pelvic fracture and an unstable pelvic fracture. And when we look at stability and instability, we don't want to get the nomenclature mixed up here. We're really talking about bony stability and bony instability. Generally speaking, and we're not going to get into a deep dive into this tonight. I've got a whole different lecture maybe I'll do sometime on pelvic injuries. But generally, stable pelvic injuries are stable pelvic fractures are those that really involve the periphery of the pelvis. They don't typically involve the pelvic ring. And they are usually, for the most part, injuries that don't require surgical intervention. They're low impact, low blunt force injury events, and don't typically result in hemorrhage. So patients actually do pretty well. In fact, you will have a number of patients with particularly minor stable pelvic injuries that may actually get discharged from the emergency department. What we're concerned about are these unstable pelvic fractures. And typically, just again, to give you just a real brief kind of, kibitz on this, it's anything that involves a pelvic ring. When the pelvic ring breaks, it doesn't break at just one spot. It's pretty much like a pretzel. And if any of you have ever been in the live lectures that I do about pelvic injuries, I typically bring a bag of pretzels. Everybody gets a pretzel, and I dare anybody to be able to break a pretzel at only one spot. It's literally impossible to do so. The pelvis is really the same way. So when you end up breaking part of the pelvic ring, another corresponding part breaks, and in the sheer amount of force that it takes to break that pelvic ring also causes ligamentous injury. And because the blood vessels are all intertwined within the very heavy ligature that is in the pelvis, tearing and shredding of vessels occur. And then as a result, bleeding occurs. Fortunately, or unfortunately, depending on how you look at it, arterial bleeding is the minimal types of bleeding that we see. Only about 5 to 20% of pelvic bleeds involve arterial bleeding. So the vast majority, again, anywhere from about 80% to 95%, tend to be venous bleeds, which still can be devastating. You still can exsanguinate, particularly if you're looking at, your internal or external iliac veins, or your inferior vena cava, where it kind of right before it bifurcates at the top of the ischium. These things can result in some really devastating injuries as well, but typically not as major as it would be with an arterial injury. So I'm not going to really get into any more than that. I've probably gotten into it a little bit more than I wanted to, but I just wanted you all to have just a kind of an across the board, fairly clear understanding of really what creates an unstable pelvic injury. And it's not a pelvic injury with hemodynamic instability, it's first and foremost bony instability, and then if there is underlying vascular damage, that instability that ensues from hemorrhage. So as part of this study, they chose to look at, they chose to look at pelvic compression devices that are out there. They know that these are widely used. And they should be widely used in the early treatment of pelvic injury. The devices typically work by external circumferential compression that reduces pelvic volume by taking, again, unstable pelvic fractures, that pelvic ring, which is now broken and is now expandable. If there's hemorrhaging that occurs within its confines, it now restabilizes it, puts that counter torsion externally, and theoretically can assist in tamponading off of bleeding. So maybe instead of by expansion, you dump 3.5 or 4 liters potentially into your pelvic girdle. Maybe by doing the circumferential compression, you can limit the bleeding to 1.5 liters or 2 liters. And again, not overly scientific. There's been no, randomized controlled studies that have shown this. This is just what has been done theoretically and what they believe based on some cadaver studies that have been done out there. There are a variety of pelvic devices that are out there on the market. Again, this is not a commercial for any of them, but they're out there. If you are not using a pelvic compression device, particularly in your department, you probably have to ask yourself why. If you are, and I hope everybody is, be familiar with the ones that you are using. The one to the far left is the common bed sheet, and that for the longest time was one of the primary at least hospital-based pelvic binders we were using. In the pre-hospital setting, believe it or not, we were using pneumatic anti-shock garments, the old mask pants, for a while for those agencies that were still carrying them. And it really wasn't that long ago that they finally all came off of ambulances here in New Jersey. Those were being used, and probably not the best thing in the world to use. And the other thing they were using is they would invert the Kendrick extrication device, which is the KED device, which maybe you used to remember seeing if you've been around long enough, that patients would come in after a motor vehicle extrication. They have this giant green binder that would be placed on them around their waist, up against their head, up against their neck, and everything would be immobilized kind of from the waist up. You can invert those, put those over the pelvis, and actually cinch down on them, and you can actually get some stabilization of the pelvis. The problem is that people were over cinching them. They were not cinching them in the right way. And again, these are not objects or products that were manufactured for pelvic splinting, so they really shouldn't be used anymore. Certainly, I am an advocate that every EMS agency, every trauma center, every emergency department should carry a commercial compression device for pelvic binding, just as I'm an advocate for commercial tourniquets and for commercial chest seals. I know Catherine's giggling right now because she knows I get on my soapbox about this, but the reality is that use products that are made for what they're used for. Only MacGyver things when you absolutely have to. Okay, you drive your car off a cliff and you're at the bottom of a ravine and you've got a Twix bar and a bottle of water, then okay, MacGyver it. But if you're in a modern emergency department, we should have equipment that is appropriate for the task at hand. All right, getting off my soapbox there. So the objective for this particular study was to evaluate the use of simulation training on pelvic compression devices. And they used medical students because I'm not really sure why medical students over everyone else, probably because they were a bit of a captive audience over there. And then they wanted to determine, after some training, the number of applications that was required in order for these subjects to meet proficiency. And they used the word proficiency and competency a little interchangeably in this talk, which is another vice of mine. You're going to find I have a lot of vices, but they use them interchangeably. And they just really wanted to see how long it took for somebody to actually apply this device 100% correctly and how many attempts it took, which I thought was kind of interesting and novel. The methods that they use, pretty straightforward. This is where statistics come in, and I'm not going to get overly heavy in statistics tonight. Don't worry about that. So they use what's called an observational cross-sectional study design, which really means they were observing a number of variables, just observing them. And they were recording those observations of multiple variables. That's it. There is no interference. The person who was recording the variables should not have been really involved with any, certainly during the actual testing, should not be involved in doing anything other than observation. And sometimes even that observation has kind of an adverse or a negative effect against the entire premise of what you're doing your study. Some of you may be familiar with what's called the Hawthorne effect, and the Hawthorne effect basically says when you know you're being watched, you tend to do things the way you're supposed to. But when the roosters are away, the chickens play. So sometimes that is an issue there. But and that's something that's part of the weaknesses of almost any study that there's observation from. So they use this observational cross-section design. They developed a schema, which they really decided, you'll hear it a little bit later on, that they needed a sample size of at least 70 students or 70 subjects in order to really have the right number of subjects they needed to do in order to really kind of have statistical prowessness, if you will, to the work that they were doing. They managed to recruit 132 volunteers, which is pretty good. Each subject was observed performing 10 consecutive pelvic binder application using the T-pod tourniquet. Oh my goodness, the T-pod pelvic binder. Each application was evaluated using a stepwise approach, which was outlined and provided in a training curriculum about 2 weeks prior to the actual subject testing. And in addition to looking at the stepwise approach, there were a total of 6 steps they had to get correct. They also looked at the application times, and they recorded the amount of time it was taking to apply the binder, which is also kind of interesting because obviously when any kind of a skill like applying a tourniquet, packing a wound, putting a pelvic binder on, applying pressure, the quicker you do it, the better it is. But there's never been anything really in the literature that really looked at optimal amount of time or suggested amount of time for this to go on, and nobody's ever, to my knowledge, recorded actual times to put this on. So this was a little interesting nuance that they did here. And then just to kind of put the icing on the cake, they had each subject do a pre and post confidence survey that basically asked them, it was a quick yes or no survey that basically asked them 4 very quick and simple questions, which we'll see in a little bit here. All right, so they initially brought all the subjects in and they did a 30-minute didactic session. And during this didactic session, they did basically everything you ever wanted to know about emergency management of pelvic trauma and the use of a binder, but we're afraid to ask. I've actually reached out to them. I hope it doesn't come in Turklandish. But I'd like to see actually what that curriculum is, because 30 minutes to talk about pelvic injuries and application of a pelvic binder, or at least walk through it, that's pretty short. So I don't know. I always talk way longer than I need to, but 30 minutes just doesn't seem manageable, but they managed to do it. They also taught them a 6-step application process, which was really out of the product manual for the T-pod. And then following the didactic session, they had all of the subjects apply a binder on a full-sized simulation mannequin. A couple of notes that I made here, there was no notation as to what level of competence was any of the participants had prior to participating. And they also didn't note as a result of sitting in this 30-minute didactic session and then walking through the 6-step process as to whether or not everyone was at least comfortable in applying the pelvic binder after that initial session, leading up to the actual observation 2 weeks later. And they also didn't note at this particular time how long it took these individuals to put the pelvic binders on during this initial setup, which would have been nice to know. It would have given a nice baseline that it could have been future data or the data captured in the study could have come back and done some comparators to. The graph you see here is the T-pod. For those of you that are not familiar with the T-pod, it looks a little bit like a corset. It's not a particularly difficult device to put on. There are simpler ones to put on out there. It's a very efficient way of binding the pelvis, and certainly once you are comfortable using it, it really is not that big a deal to use. Although because of some of the steps that are involved, particularly the measuring and the cutting, sometimes it causes people to take shortcuts, which maybe we'll talk about during the discussion later on when we kind of all turn our cameras on and chat a little bit. But this is a 6-step process they basically looked at. We'll go into it in a little more detail in a minute. What they did is they did this initial didactic training, the initial hands-on, and then they sent everybody away. And then 2 weeks later, they brought individuals back. They brought them back in groups of 12, and then they monitored them. And they were monitored putting the pelvic binder back on 10 different times. And for each time, they used a checklist that had the 6 steps on it. And then they rated them both in whether or not they were correct or incorrect in the way they applied the pelvic binder and the amount of time it took to do it. The monitoring was done by a monitoring evaluator who just basically ticked boxes that said, yes, they followed the right, manufacturer's recommended way of popping the binder on. And then there was an attending emergency physician who then finally arbitrated and judged whether or not the application was adequate. And whether or not it was I don't know if it was a pass fail or whether or not it was inaccurate or it was accurate, or incorrect or correct, I think is how they termed it. Anybody want to pop on real quick? Just turn your audio on and take a look at the binder that's here and tell me if you notice anything wrong. Any of my T-Pod super users out there? Don't be afraid. Nobody pops on, I'll give it away.
It's Kathleen. But you don't like that they folded it as opposed to cutting it?
I hate the fact that they folded it.
You do? I like that they folded it.
They're not supposed to fold it.
Okay, but I'm going to argue on the other side of it that let's just say hypothetically you're not really professional putting these T-Pods on and you cut it too short and you cut it too small. Then you're going to have to go back and pull another one out and start again. So I think it's good to fold them, because then if you have much more of an ability to adjust easily. So that was the reason why I always like folding.
And I don't disagree with you. I think if you're putting it on an average sized normal adult where you could fold it over and you're not having to wriggle the patient back and forth to get that folded over under them, or you're not having to fold it over on itself multiple times. And that's particularly what I have an issue with there, is that's folded over multiple times there.
Yeah, no, you don't fold it like you fold it in on itself. Like
right.
It can't wrap around the patient. You fold it in on itself and then it still creates that good pulling effect to pull the pelvis together. But then you have the ability to adjust it to make sure you're supposed to have 1.5 inches or so in between the edges when you pull it, and it allows you to do that.
5 inches.
So I don't know.
5
inches. Is it 5? Really? I thought it was only like
See,
oh my God.
You learned something
much?
new.
Funny, I'm thinking of the picture. Okay.
That's okay. That's okay.
I need you back. I have to go look at the directions again.
That's right. I know, we all do, right? But no, actually it's between, they say 5 to 6 inches between the ends to pull it together. Can you believe that?
Interesting. Okay.
So, but to your point, and look, I love arguing a good point, and you make some really good points that I definitely think is correct about this. And I think the problem really and truly lies in the fact when people are folding it back over and they're not doing it correctly. And we were teaching in an ATLS class about 1.5 months ago, and one of my trauma surgeons who was teaching the circulatory sedation, where they go over the pelvic binder application, actually had what they called a orange, white, orange method of doing this, where you fold it over and I was so confusing to me. I finally stopped him and said, look, dude, pulled him aside. Teach it the way the textbook teaches, or teach it the way the manufacturer teaches it, because you're confusing me on this, and we don't need to confuse a bunch of novice people. But unfortunately, if you go on YouTube, and I'm sure some of you will, you Google T-Pod application, you will come up with the manufacturer's correct way of putting it on, but you'll come up with at least 10 other videos that put it on wrong. And one of the ones that put it on wrong, and it kills me that I saw this, is one of the MRAP videos that's up there. And for anybody that knows me, I love MRAP. I've been
they did it wrong.
Yeah, they did it wrong. They did it wrong. I'm like, oh, it cut to my heart. But in addition to the fact in this, they folded it over multiple times. If you also look at the way this isn't even cinched together completely. What you're supposed to have is the buttons should be coming together and almost touching the white to the white as you're pulling on the pulley system.
It should be even on both sides. It's not
exactly.
It's not set up properly. And I love that they've got like a little Foley catheter hanging off the side there.
Yeah,
is that real? How did they get that in?
I don't know if it's real or not, but I hope they checked for blood at the urinary meatus before they did that. All right. So let's talk a little bit about kind of what they did. So the binder applications were, again, recorded by direct observation. There was a 6-step process that each person was supposed to follow. And this came interesting to me, and this is not part of their limitations section, but it really, to me, is a major limitation here. After each application, the subject was given a 5-minute break and provided feedback on the incorrect steps that they did. I mean, hello, if they did it wrong, give them the instructions and let them sit down, but don't give them any kind of verbal feedback on stuff. Isn't that kind of giving, like, when you get it wrong, I'm going to give you the answer and then I'm going to let you go take the test again? So I think that's a bit of a limitation here. If you're telling people what they did wrong and then letting them go back and do it again. I don't know. That's just my own personal thought on that. All right, so here are the 6 steps that they were either marked correct or incorrect doing. The first step was passing the belt under the pelvis. Um, from my standpoint, anyone who doesn't do this is not even anywhere near putting this thing on right, even to begin with. And not only do I not want them in my study, I think I don't even want them in medical school at this point. But that was step number 1. Step number 2, Kaplan, not cutting the belt. So the logic there, and again, it's based on the manufacturer's recommendation application, is to cut 15 to 20 centimeters or 5 to 6 inches apart, so that when the ends are 5 to 6 inches apart, so when you put the pulling system on, you've got about 5 to 6 inches of pulley strength pulling together. The third thing was asymmetrical or non-symmetrical fixation of this hook and loop support pulley system, which meant instead of putting it on straight, you put it on somewhat candy-wampus, and then when you went to pull it, what were you going to get? Well, you were going to get asymmetrical pulling of the pulley system, so that you'd end up with a device that may be shifted and had some kind of a terse compression to it, which does make sense. But it seems to me, if you didn't get 3 right, you're not going to get 4 right. And guess what? Wait till we look at the results. Failure to fix the pulley tab, which meant after you hit the pulley, there's a series of tabs that you have to kind of put the string around before you lay the little pulling device down against the Velcro. If they didn't do that right, then they got point taken off. And then, and this doesn't really go to the fact of whether or not the pelvic device was put on correctly or not. It really is a procedural thing, but they got points knocked off if they didn't record the date and the time. And I don't know about you, I have put on probably 30 pelvic devices in my life, and probably half of them T-pods, and I've never remembered to write the date or the time on it. Doesn't mean I didn't put it on right. Doesn't mean it wasn't doing exactly what it needed to do. So it's kind of interesting that they kind of looked at that and failed people as a completion because they didn't do it. But again, for following the manufacturer's recommended way of doing things, all right, I guess you kind of have to give them props for that. And then they had them do this survey. So they had them do a 4-question survey. It was a yes or no survey, and yes, I have a problem with that too. They asked him, do you consider yourself competent in the management of pelvic trauma? Do you consider yourself self-sufficient in the use of a pelvic splint or a pelvic compression device? Do you believe that the pelvic compression device practical training will contribute to your pelvic management? It's an outcome study, a level 5 outcome. And are you confident in using the pelvic compression device in pelvic trauma? So the questions weren't unreasonable. I just have trouble with the yes or no response because, this isn't a yes or no thing. This really is anything I think that's procedural should be more done kind of on a Likert scale to get a little bit better view. Like, yeah, I kind of think I do, but I'm not 100% there yet. So as opposed to almost cajoling me into like answering yes, because I don't want to answer no, because then I look like I'm wasting everybody's time. So again, that's just kind of Steve's eye view of maybe it would have been a little bit better constructed to do like a 4 or 5 point Likert scale questionnaire. All right, then there's this. Oh my God. So we're not going to spend really any time on this. This was really kind of a study that, unfortunately, sometimes to get these studies published, you have to do a higher level of statistical analysis, and probably you really need to do, and they probably didn't need to, but a lot of it because they had multiple little observations or what are called categorical variables that they were looking at here. They needed to take it through a variety of really fairly standardized statistical analysis, and this is all of the stats that are done here: the McNemer test, the chi-square, and then ultimately looking at the p-values. All of these are pretty much straight out standard kind of stuff you see in almost every study that's published. So I'm not going to spend a lot of time on it, other than particularly when we get to the p-value area. P-values really are kind of like percentages and likelihood that the positive attributes of a study are not happening by random chance. So particularly they look at basically 5%, anything that's less than 5%. So any of your scores, any of your statistical analysis that comes up with a p-value of less than 0.05 or really 5%, then that's considered to be statistically significant, and that really your hypothesis, it maybe holds a little bit of water is what it means. They decided the number of subjects needed to carry out this process was 70, and the number enrolled was 132. So they definitely, over succeeded in getting the number of volunteers to participate. When we looked at it, there was a good spread between male and female medical students, about a little more on the female side, 51.5, 49.5 for the male. Interestingly enough, the highest correct application rate was 97%, and that was on the 8th attempt. Eighth. That's between 7 and 9, which just kind of floors me, but okay, it is what it is. The highest number of missed items was on the 3rd attempt, and as the number of attempts increased, not surprisingly, as the number of attempts increased, the number of incorrect applications decreased. The more you do it, the better they became at it. Absolutely. And as the number of applications increased, the time to apply decreased. Although the question was, is this statistically significant that they went from 90 seconds to apply it initially to a whopping 84 by the 10th time they were doing it? So did they really knock that much time out? And is that time really a big a deal? And then what's the benchmark? What really is the recommended amount of time to put on, a pelvic splint? So, and we don't know that. It's not out in the literature. So maybe one of the side benefits of this is maybe they've helped to establish a little bit of a benchmark for future studies when it comes to timing of these applications. Here is the results of where the steps were missed most commonly. So this just kind of, again, just makes me kind of shake my head. Step 1 was missed, at least initially. 15% of the people, when they first went to apply it, didn't think to wrap it under the patient. I don't get it. I don't understand it, but there it is. And then step 3 and step 4 were the other steps that were most likely missed. And again, they're tied together. If you asymmetrically apply the pulley device, you're going to asymmetrically pull them together. Although, interestingly enough, they had a lot more asymmetrical applications than they had actual asymmetrical endings when it bind together. I don't quite understand how that happened, but again, that's what they are reporting. Certainly for each of these steps where they had these mishaps, as they did more of these, guess what? The errors became less and less and less. Again, not unexpected at all. It's certainly good to see that practice makes perfect, right? But almost perfect, not entirely perfect. And then here's where a little bit of the statistical wizardry came in, where they looked at these p-values. And the reality is that for the first 3 applications, they had as they were getting progressively better, there was a lot of p-values that were really almost as good as you can get, which is 0.0001 or like 1/10 of 1%. So certainly for the first 3 applications, they demonstrated statistically significant betterance in putting the applications on. After that, it incrementally got a little bit better, but it didn't rise to anything being statistically significant. So one could really walk away saying, from a statistical standpoint, really the 3rd application was probably as good as it got, and anything after that was just an incremental betterment, if you will. Statistics can drive you nuts, right? Rate of competence in the management of pelvic injuries. So this is the pre and post little questionnaire that they did with the yes or no answers. Pre-participation study showed that only less than 20% felt competent in the management of pelvic injuries. Maybe they've got a really good medical school program over there, but 19%, almost 20% of the medical students felt they were competent in managing pelvic injuries. Wow, that's pretty good. Post-study, they got up to 96%, even better. Competence in the application of the pelvic binder, 1/4 of them thought they were competent to begin with. That was wrong. And then at the end, 95% felt they were competent. And that does bear itself out from the numbers that we see at the 8th application mark, where they hit about 95% when it came to the number of individuals being correct in putting it on. But 100% believe the training would improve overall some level of their ability to manage. So again, self-reported. The self-report here, particularly the 95% with the competence for the application, ended up being shown in the statistics, which I think is good to see. Again, the author stated it took about eight applications to achieve, a 97% correctness. And again, with each successive application, the application process got better. I do not know why, and they did not explain why when they got to the 9th and 10th application, they lost some people. They didn't explain it. The amount of time to put it on continued to get better, but for some reason they dropped about 4 or looks like 6 people kind of screwed up in the last 2 applications, but still hitting about 97% effectiveness across the board isn't a bad thing at all. So in their discussion, they kind of go on to say, and this again goes back to look at the literature, which is true, the use of pelvic binders is really spotty at best in both the pre-hospital and during initial trauma resuscitation in the trauma bay. And this is true. And I think a lot of this is in part to the fact that pre-hospital clinicians really wrestle with when they should apply a pelvic binder, and some even question whether or not they're allowed to apply a pelvic binder. I was actually getting ready to do a talk for one of the EMS agencies that serves St. Joe's. And when I turned my content into the State Department of Health for continuing education credit, the Office of EMS actually came back to me, and I had to demonstrate to them, the regulators of EMS in the state, that basic EMTs could apply a pelvic binder. And I had to go through the literature and show that it was in the basic curriculum, and that there are a variety of courses that are out there, blah, 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 blah. And they finally said, oh, okay. So if the state is not even sure about it, then we can only imagine poor clinicians out in the field may or may not know when and why to do it. And then Kuhn et al. Showed that 33% of pelvic fractures treated in a resuscitation bay at a level 1 trauma center did not have a pelvic binder put on. And again, I think that's because those of us working in the trauma center were a little bit conflicted and confused as to when we should apply a pelvic binder. And I mean, for those of you that are out there that are in trauma centers, and particularly that are on live tonight, to the extent you want to share, in a minute, I'm going to open this up. I'd love to hear what your thoughts are on this, and whether or not you sense there's some level of confusion as to when to put it on and when not to put it on. Vodja found that 47% of patients transferred to a level 1 trauma center with unstable pelvic fractures, that's again, bony unstable pelvic fractures, had a binder applied. So less than 50% at that. And then ATLS is now certainly recommending ongoing training and pelvic binder application beyond what is ultimately taught during ATLS. And they're recommending devices should be placed prior to x-rays. It's like a tourniquet, it's like wound packing, it's like direct pressure. Anything that's compressed, anytime you can compress some level of a hemorrhage, it should go on really as part of the ABCs. We certainly teach this in TNCC. In fact, there's at least one case scenario in the TNP where it is a pelvic injury, and you're talking through putting your pelvic binder on as part of your ABC. So here's a question. I'm gonna open this up in a minute, and I'd like to just hear if anyone was willing to answer. When do you think a pelvic binder should be applied? Let's see. There was another study that was done. Pelvic binders are often positioned incorrectly. So this became another problem: is where do we go? How do we put them on? Where are they supposed to go? And really, the greater trochanters are the benchmark. So the midline of any pelvic device being put on should occur at the greater trochanters. I teach this quite a bit. I teach medics, I teach EMTs, I teach nurses and docs, and the answers are always all over the board. Some will say at the level of the iliac crest. Some will say at the level of symphysis pubis. Some will say correctly at the level of the greater trochanter. These really are more greater trochanteric binders than they are anything else, but that's really the lot. So really, even on the most obese patient, if you can find the symphysis pubis, draw a straight line across, and that's really going to should be in line for the most part with the greater trochanters, and that's where the midline of any device should reside. Not too high, not too low, because you can the device won't have the circumferential grab that it needs to have. And then they kind of said, based on review of the literature, training certainly should be scalable. It should be done. There is an ongoing need to do it on a routine basis. And I think, again, any of us that do education will agree, use it or lose it. So even like with the basics of putting a tourniquet on, I published a study about 4 years ago that showed tourniquet use, using a commercial cat tourniquet, that if you're not using it on a regular basis, people have like marked degradation in their application skills between 3 and 6 months after learning how to put a tourniquet on perfectly. And then the limitations that they identified, I think there are a lot more than just the ones they identified, say, they only use a T-pod device. So this is not generalizable to other forms of pelvic splints, particularly something that you put on like the SAM splint, which is a much easier pelvic device to put on. Unfortunately, it's not as much of a one size fits all like a sheet or a T-pod is. There's also another device out there that's called the pelvic binder, which is just like a T-pod. And then there's another one that I saw today. It is it's an elastic circumferential splint that's developed by the Israeli military. I think it's called the Israeli circumferential pelvic binder or something like that. We're gonna have to go out and buy one now and play around with it. But so you have to know what your device is to be competent in using your own device. They used mannequins in the study, and mannequins are not humans. So the question is, can we do some cadaver or human studies, or use cadaver or humans as a basis for doing this? I would probably argue if you got some healthy, medical students, they can be putting these things on themselves. At Joe's, when we're doing our trauma training for our nurses, we do pelvic binder application, and we just have them put the pelvic binders on themselves, just like when we do traction splints and tourniquets and things like that. And then the selection bias. Every study reports this. Did they pick the right students? They really didn't say how many of those students had pre-hospital experience, how many of them had been medics, how many of them had been nurses. That would have been nice to know, because if 50% of them were medics and nurses and had previous experience, maybe they shouldn't have been included in the study. Maybe it injected some bias to the study. And then the conclusion, and I think we'll all agree on this: pelvic binders can be or should be considered crucial. This represents the first study to really measure application, number of applications needed for competence, as they describe it, and then kind of setting a benchmark for timing of the application of these things. And then last but not least, they found 8 mannequin applications were required to achieve what they called proficiency, which was 97% of their subjects. I don't, you be the judge. I mean, they were up in the mid 70s by the time they hit the third. If they were only looking at not writing on a label, or maybe not putting these things together correctly as a benchmark, but the splits were still going on, the binders were still going on correctly, they still were doing circumferential binding, is that really, could we kind of wiggle a little bit? I don't know. All right, so like you to tell me what you think. I'm going to stop sharing my screen for just a second.
So it's Kathleen. I have one comment. I think what I find a little bit frightening about that study, quite honestly, is that these students have come away with the self-evaluation saying that they feel competent to care for somebody with a pelvic fracture. And that's a little scary, because until they get into the trauma bay and know what they actually really feel like, or what they really, how they are really unstable they are, or what exactly a pelvic fracture means. I hope this wasn't going to give them a bunch of false confidence. Certainly the skill of putting on the pelvic binder is really important, because I certainly found that residents knew what it was, but they couldn't always figure out how to get it on.
Right.
But so that skill is important, but I wonder if they think now that they can just go in and manage a pelvic fracture.
Yeah, and I'll tell you, that was my worry as well. And again, without the true adrenaline rush, and that's why I'm saying they called this a sim, but this really wasn't a sim. I don't look at it as a sim unless you've got smoke flowing and people are screaming in your ear and they're squirting blood in your eyes and stuff like that, right? So you got to wonder if that was kind of the inject at which they were doing for each of these 8 applications. It might have taken them more in the order of 25 or 30 applications to get it right? But I agree with you. I think anytime you start, that's why I say I have a real vice with the term competence, because competence is so subjective, right? And just because I don't put it on exactly the right way doesn't mean I'm not competent. It also doesn't mean the device isn't working, but again, subjectivity there, right?
Yeah.
Any other thoughts?
You know, I keep going back to that step 1 where they said it wasn't under the pelvis. I wasn't taking that to mean that it wasn't under the patient. I was taking it to mean that it wasn't positioned correctly, that it wasn't over, under the trochanter or over the trochanter, like maybe it
Yeah.
was too high up on the pelvis,
Yeah.
too low. Maybe it was positional more than they just like slapped it on the top and tried to like jerry rig it.
Yeah. And again, I'm totally with you on that. Again, there wasn't enough of there wasn't really a lot of an explanation as to what each of those were. I went back and tried to look at the quote unquote manufacturer's, little thing and it didn't find one. Unfortunately, I need to go down to my trauma bay when I'm back in the hospital on Friday and actually open a T-pod down there and see if there's actually pull the instructions out. Because I Googled and I didn't find any, but maybe I didn't Google right. But it'd be interesting to know. But I agree with you, Kenzie. It's kind of like, not exactly sure. And I'm also not 100% sure about what they mean about, misalignment. I think I know what they mean, but I'm not 100% sure. But here's the thing. They had a lot more people put the little pulling device on cattywampus, but there wasn't that same number that when it came together, it was still cattywampus. And I've got to wonder why that's not the case, unless the person was just complete. Well, no, this was a mannequin they were putting it on. So the mannequin wasn't like, in kind of weird fashion. So I don't know.
I wonder if we lost some stuff in translation too, because this is Turkey, right?
Yeah, could be.
So maybe we lost some information in translation.
Could very much be.
Yeah.
That's a good point. Anybody else have any thoughts on this? Anybody else using any of these devices either in their emergency department, maybe some pre-hospital experience to put these things on or not, or this is the first time you're even kind of seeing what one of these devices are, right? I hope not, but I mean, if you are, then like I say, you need to be kind of finding out within your own institution if you are carrying these devices. And again, it doesn't make any difference if you're trauma center or non-trauma center, you are going to see a patient who comes in with trauma. You're going to see that motor vehicle crash that comes in by a ambulance provider that doesn't appropriately triage or maybe doesn't understand the true seriousness of the injuries and bring them to you. Our little community hospital that's part of my system is constantly getting some really sick trauma patients that sometimes are misrouted or misguided by BLS and they're brought there, or they come in by the front door. And don't think because I was involved in a bad motor vehicle crash or a motorcycle crash or a long fall that I'm not going to show up by the front door in the back of a truck, laying in the back seat of a car, So again, all of this thing kind of leads into the fact that we all have to be prepared in some way, shape, or form to stabilize initially that trauma patient and then effect an efficient transfer. But again, part of the ABCs, if you will, whether you're looking at the primary survey in ATLS or the TNP for TNCC, or you're looking at the initial assessment, if you will, for pre-hospital care providers, this is all kind of part and parcel to doing that correctly, at least in my opinion.
The other thing I would say too is that most centers don't actually have T-pods or any of the other sort of commercial pelvic binders. Like if they really wanted to test their competency or test their skills, they should have had them use the sheet method. Because in fact, a lot of people feel that the sheet method actually, like when you put somebody in a T-pod and then you put somebody in a sheet method, we've done this with students, they actually say sometimes the sheet feels more secure, which is interesting.
Yeah.
And, and actually the sheet is less accurate. Like you have to kind of know how to do it. The T-pod is kind of no brainer in a way.
Yeah. Oh, absolutely it is. And the SAM splint is even more so. I mean, it literally has a pulley in there that the teeth pop out and won't let you pull it anymore once it hits the desired tension that the device is intended to provide. So yeah, and I'm with you. I mean, for years, I was really an advocate of using the sheet until I got turned on to the T-pod and I actually used the T-pod once in the pre-hospital setting. And it was like, oh, I'll never go back. I mean, I carry one in my car just because if I get on scene and the ambulance doesn't have it, I got mine. But that being said, I agree with you. And you know what? That's a good point. Look they've done some studies and they certainly show, again, like with anything, the commercial devices do a better job of circumferential tension and kind of, even if it's just in time reading the directions as you're putting them on, probably go on a little bit better than using the sheet method. But the sheet method does work very, very well. No doubt about it. All right, we're coming up on the 9 o'clock mark. Anybody else have any questions or comments? All right, so let me share my screen with you one last time here. I'll give you some parting stuff here. Let's see. My buttons got cattywampus. Here we go. Boom, boom, and boom. Okay, so if you got your cell phone on you, take it out, get out your QR code reader and scan the code. If not, I am going to right now in the chat box put the link that you can just click on from the chat box for, oh boy, kind of got goofy. There we go. Boom. Just do me a favor. You want credit for tonight? Please take about 3 or 4 minutes of your time. Go to this link and fill it out. Give me your information. Tell me whether you found tonight's session to be helpful or not. And we'll give you an hour of continuing education credit for your efforts. Again, if you are like-minded and you want to be included in future installments of this program, please indicate that by giving me your email address at the end, which I would be grateful for, or just actually, no, just, I think it's just a question that says, yes, I do want to be involved. And I'll invite you to future installations of the Journal Club and the other companion program that I do, the topics in trauma nursing. And I'm also, like I said, after tonight, after I render this and get this posted on YouTube tomorrow, I'll send all of you a link, and anyone who registered and couldn't be here tonight, I'll send them a link. And I'll keep the continuing education credit active for probably about 2 or 3 weeks. So, you know, anyone who in the next couple of weeks goes on and watches the YouTube, they'll be able to flash on the QR code on the screen from the YouTube video and fill out the evaluation and get credit as well. And I think that's probably about it. So in closing, does anybody else have any questions or comments? For the good of the order, as they say.
That was great, Steve. Thank you.
No,
Thank you, Steve. It was really nice. Thank
Yeah,
you.
thanks, Hannah. Thanks, Kenzie. Thanks,
Yeah, it was
Allison.
great.
Allison, glad to see you.
Thank you. I feel like the most important thing that I'm going to take after this is advocate for my facility to actually provide some pelvic binders.
Yes, you guys don't have teapods. Yeah, you need to get them. So talk to me.
I will tell you this: a teapod runs, and again, depends on who your vendor is, anywhere from $120 to $130 each. The SAM splints run about $70. However, teapods, bed sheets, those are almost a one-size-fits-all. The SAM splints, you have to buy a small, a medium, and a large because it's not a one-size-fits-all thing. So there is some drawback to it. But absolutely, Allison, definitely advocate for the teapod, you know, at the very least, and you know, stay competent. So other than that, thanks for everybody for joining us tonight. Without further ado, appreciate it, and hope to see you soon. Take care.
Thank you. Take care.
Thank you.
Bye-bye.
Bye.